This part of the lecture will be on physical examination of the knee. The knee is the largest joint of all the major joints in the body, and it is one of the inherently unstable joints, and it relies heavily on the ligaments to maintain stability. Before we forget at this point, I just want to make sure we remind especially our students that anytime we're examining the knee, especially in young patients under age 15, we need to always consider growth plate type injuries, which we won't be discussing further on from here. Also, we need to consider growth plate injuries to the hip in patients between ages 11 and 13, a condition called slipped capital femoral epiphysis. We're going to divide the physical examination by looking at inspection, alignment, looking at the range of motion, as well as looking at the sensation and looking for some special tests to look for instability problems as well as meniscal injuries. The first part of the examination is looking at inspecting the knee, just visualizing if there's any problems. Of course, obviously, the very first thing we'll look at is the patella. We want to see, is the patella dislocated, subluxed to the side. The next thing that we usually look for is there any swelling overlying the patella, which would be prepatellar bursitis, which is something that we frequently see in athletes who do a lot of wrestling, as well as in roofers, as well as concrete and carpet layers. The bursitis basically is a term that we use for a sac that is overlying the patella, between the patella and the skin, that can fill with fluid in inflammation, or sometimes can get infected and you can have a septic prepatellar bursitis. Next, we look at the quadriceps muscle. Again, the quadriceps muscle is made up of the rectus femoris tendon, which inserts onto the patella, the vastus medialis, the vastus lateralis, and of course there's the vastus intermedius that we can't visualize. It is immediately posterior to the rectus tendon. We also sometimes will hear the vastus medialis obliquus. This is part of the vastus medialis that attaches onto the patella, and that's what stabilizes the patella and keeping it from dislocating laterally. In regards to the proximal tibia, we look for the tibial tubercle, where the patellar tendon inserts onto the tibial tubercle. The other name for it is tibial tuberosity. We also look at the Gerdy's tubercle right here, which is just lateral and superior to the tibial tuberosity. Gerdy's tubercle is the attachment of the iliotibial tract onto this area. The other thing we look for, especially on the lateral side, again you can see the fibular head is in this region. Many times first-time examiners of a knee will consider this being the fibular head. We need to realize the fibular head is this far lateral. The other thing we look for on the anterior part of the knee is the pes anserine region, which is the attachment of the sartorius tendon as well as gracilis tendon and the semitendinosus tendon. And this would be just immediately medial to the tibial tuberosity. Again, here you can see Gerdy's tubercle would be at this level, the fibular head in this region, tibial tubercle, and this is the pes anserine region with the attachment of the sartorius fascia as well as the semitendinosus and the gracilis tendons, which are frequently utilized in anterior cruciate ligament reconstruction. On the medial aspect of the knee, we're looking for the medial collateral ligament, as well as the adductor tubercle, the attachment of the adductor tendons. We've discussed already the lateral side, where we looked at the fibular head as well as the lateral collateral ligament. And Dave, could you please bring your knee up like that? Just stop it. Actually, okay. We're now again looking at the lateral side of the knee. Again, fibular head down here, the joint line right there. And you can see the biceps femoris tendon is in this region attaching onto the fibular head. Good stuff. Posteriorly, we are looking at the popliteal region. Baker's cysts are frequently found in this region, and this is basically an outpouching of the capsule of the knee that fills with fluid. Usually we see Baker's cysts more in patients that have degenerative arthritis, and they get fluid building up in this sac in this region. The next part of the examination is looking at alignment. The physiologic alignment of the knee is in 5 to 7 degrees of valgus. Again, with alignment of the knee, we are looking for a normal valgus alignment of the knee at about 5 to 7 degrees. If his knee was significantly knock-kneed, we would term that genu valgum. If the knee was extremely bow-legged, we would term it genu verum. Alignment.
Okay.
We also observe the alignment of the patella. If the patella is facing too far in, we call it a squinting patella or an in-facing patella. If it's laterally facing, we term it an out-facing patella. The other thing that we look for as far as the patellar and the patellar alignment is the quadriceps angle. The quadriceps angle is an angle that we take from the anterior superior iliac spine to the middle portion of the patella, and from the middle portion of the patella to the tibial tubercle. If this angle is supposed to be about 10 to 15 degrees, again, that angle like that. If this angle was significantly increased, then we would be having problems with patellar maltracking and the patella tracking over to the side and dislocating. So the quadriceps angle is also something that can be looked at for evaluating patellar tracking, although it is pretty difficult to judge, and there's a significant inter-observer variation whenever measuring that angle. In regards to alignment, we also look at the gait pattern when the patient is walking. An antalgic gait is when a patient just barely puts a little bit of weight on that foot and significantly decreases the time in the stance phase on that leg to decrease his pain. The stiff knee gait is with walking with just a stiff knee. Sometimes patients with quadriceps tendon rupture or patellar tendon rupture, they're unable to flex the knee any more than that because their knee would buckle on them. Okay, come back. The flexed knee gait is if the patient has a bucket handle tear, they're unable to fully extend the knee, and this is a gait that we would usually look for. With the knee, if the patient is walking like this,